In this slideshow, I want to go over COPD and chronic bronchitis and emphysema, but I want to go a little deeper than what we were able to do in class. So, as always, we start with objectives, and we're going to talk about COPD and understand that both emphysema and chronic bronchitis are the two major presentations of COPD. And we're going to discuss really how prevalent it is in society and its economic impact on our society. We'll talk about the signs and symptoms of COPD. We'll differentiate, and I don't really like these terms. I got to tell you, I really don't like them, but they're there, so we will use them. We have to differentiate between pink puffers and blue bloaters. Describe treatment plans for patients presenting with COPD, and then at the end we're going to talk about hypoxic drive and how we can avoid complications from it. So emphysema and chronic bronchitis. In both of these, the lungs have been permanently altered. It is not a temporary condition. It is not a curable condition. Once you have emphysema and chronic bronchitis, you pretty well have it for life. And what happens, the airway in the lungs are constantly narrowed, and the patient has chronic inflammation, and this creates great difficulty in breathing. So some facts, 16 million people are diagnosed with COPD. It's probably more than that, but these are how many are diagnosed. And now when you kind of think about it, you think, well, we probably see emphysema patients more often. True, we probably see emphysemic patients more often, but there are actually more chronic bronchitis patients out there, about a 7-to-1 ratio, 14 million with chronic bronchitis and a couple million with emphysema. COPD is the fourth leading cause of death in the U.S. It's taken over stroke. It's pushed stroke back to the fifth place. Probably the biggest reason for this, kind of twofold. One, we have better treatments for stroke, but at the same time, we have a lot of people smoking. COPD, both bronchitis and emphysema, have a much higher mortality rate than what asthma does. And this is an older number, but the annual cost of COPD is more than $30 billion. So that's from probably like 2016. So that's probably 6 years old. I'm sure it's much, much greater than that now. So here we kind of have a classic representation of the two presentations of COPD. On the left side of your screen, we have a gentleman who has emphysema, probably a little bit older, at least in his 50s, and you can see that very distinctive physique, that barrel cage, saying that we have an anterior to posterior diameter that's very, very close to the lateral diameter, the side-to-side measurement. You also notice that he's very, very thin. They have a tendency to be thin because very simply they use all their energy that they have to breathe. And you see he's probably got a decent color to him. He's kind of got a good pink color to him. Well, there's a reason for that. It's a thing called polycythemia. We'll discuss it later on, but it's very simply an adaptation of the body to live with those low levels of oxygen, high levels of carbon dioxide. Now, over on the right, you see our chronic bronchitis patient. And again, I'm going to tell you this a couple times. I don't like the term blue bloaters, but you can see that he's heavier set, usually secondary to a sedentary lifestyle. But he also has just a terrible color to him. He's dusky. He's almost cyanotic. You'll also notice that he's holding in his hand a handkerchief or some tissues because they have a chronic wet cough. They're constantly bringing up quite a bit of sputum. So signs and symptoms, cough with or without mucus. We see our chronic bronchitis patients always have a cough, and it's almost always a productive cough. Oftentimes on our emphysemic patients, we'll see them with either no cough or if they do have a cough, generally a dry cough. Fatigue. Both of them very simply get, whether chronic bronchitis or COPD, they get fatigued quite easily. Frequent respiratory infections. So our chronic bronchitis patients, you can hear it right in the name. They have chronic inflammation of the bronchi. They have chronic infections. Our emphysemic patients, oftentimes we don't hear from them on a normal day. When we hear from our emphysemic patients is when they have a pneumonia, when they have an infection. Obviously, both presentations have shortness of breath. On our emphysemic patients, we'll oftentimes hear no significant changes in breath sounds other than they may be diminished. If we do, oftentimes we'll hear wheezing. And then with our COPD patients, our chronic bronchitis patients, we'll hear that rhonchi. So let's discuss one of the specific respiratory diseases, emphysema. Emphysema is caused by the destruction of the alveolar walls distal to the terminal bronchi. So emphysema is almost, not quite, but almost exclusively concerning the alveoli. And they're destroyed. They get destroyed usually from cigarette smoking, more common in men than women because very simply men smoke more often than women do. The biggest contributing factor, again, is the toxins from cigarette smoke, and people get emphysema other ways, exposure to environmental toxins, but the vast majority of the time it is cigarette smoke. And as these alveoli are destroyed, they lose surface area. And as they lose surface area, they have a lessening area available for gas exchange, for the exchange of oxygen and carbon dioxide. There you can see kind of a cool picture. On the left, it shows a good normal set of alveoli. They kind of look like bunches of grapes. Over on the right, you can see alveoli with emphysema, and just very simply how they're damaged and the walls are corroded away, and we start losing quite a bit of the surface area. So we lose that surface area, we have an increased ratio of air to lung tissue. So we have more air, less lung tissue, and diffusion doesn't happen as easily. It also increases resistance to pulmonary blood flow. That blood's flowing over trying to pick up oxygen, it can't. So it ultimately causes pulmonary hypertension. Now, this is not systemic hypertension. This is very specifically pulmonary hypertension, and that leads to right heart failure, cor pulmonale, which is a group of symptoms around that right heart failure, and people die from this as part of the disease process. So it also has a weakening of the walls of the small bronchioles. Now, we discussed earlier that it's mostly the alveoli, but the bronchioles also, and that's a very important concept to think of when we start talking about treatments. So when the alveoli are destroyed and the small bronchioles are destroyed, well, the lungs lose their capacity to recoil, to exhale, and air becomes trapped in the lungs. Very specifically, carbon dioxide becomes trapped in the lungs. And these patients breathe through pursed lips. I don't really want to do an example of it, but sometimes you'll see long distance runners breathing through pursed lips also. And what this does, it creates a positive end expiratory pressure, and it prevents those alveoli and the small bronchioles from collapsing. So keep that in mind when we talk about CPAP later. So emphysema is absolutely irreversible. And once you get emphysema, you have emphysema. If you stop smoking, take care of yourself, you can mitigate the effects of it. But no, when you get emphysema, you're going to die with emphysema. These patients become very prone to acute respiratory infections. They become very prone to getting pneumonias and getting bronchitis. And they're also predisposed to having cardiac arrhythmias. And one of the big cardiac arrhythmias that they're prone to getting is AFib, atrial fib. And as you'll learn as we go through the course, atrial fib is a contributing factor, especially for having strokes. So these patients are dependent on three big classes of medication to keep them going. They're dependent on bronchodilators. We see that in the form of albuterol and Atrovent. They take corticosteroids, usually something like methylprednisone. And they have supplemental oxygen that they are continuously on at low dose. Now, this is very, very secondary to taking steroids for, well, a long time. They can cause personality changes. They can cause mood changes, and people on steroids have a tendency to get hyperglycemic, and they develop this, a moon face. They develop a very chubby, round face. They're very susceptible to infections. In male, we have gynecomastia, which is simply they develop breasts. Oftentimes, they have very, very thin extremities, and they develop fat deposits on their face that gives them that moon face, but also on the back of their shoulders. And sometimes we use rather cruel terminology, but it's sometimes referred to as a buffalo hump because that's really what it looks like. Very thin skin and these purple striae. They look like stretch marks and bruises and petechiae and osteoporosis. So at times, the cure can be almost as bad as the disease. These are all, again, symptoms or syndrome of long use steroids, not short use, but long use steroids. Now, we got to talk about capnography real quick. And we discussed this in class, but if you put these patients on capnography, you're going to see this shark fin waveform. Rather than a nice boxy waveform, you see this shark fin waveform. And that comes kind of from two factors. It's one that healthy people, when they breathe in and breathe out, have an inspiratory ratio of about 1 to 2. So if it takes you 1 second to breathe in, it takes you 2 seconds to breathe out. Our COPDers have a much greater ratio. So if you breathe in over 1 second, it's oftentimes breathing out over 3 or even 4 seconds. And what they're doing is they're trying to blow off all that retained CO2. So you'll see that very distinctive shark fin representation. It shows bronchospasm. It shows that long exhalation and blowing off the CO2, not very quickly as we do, which gives us that very vertical line on the capnography, but very slowly over 3 seconds, which gives us that gradual increase, that shark fin waveform capnography. I don't want to talk a lot about this, but if there are any paramedics listening in, this kind of gives you some EKG changes. When we have cor pulmonale, we see tall peaked waves about 2.5 millimeters in height, and the inferior leads 2, 3, and AVF. We'll also see an increased R wave voltage in leads V1 and V2, and we'll see a right axis deviation, usually between plus 90 degrees and plus 180 degrees. It's also not unusual to see a low voltage QRS complex, less than 5 millimeters in height in the limb leads. And then also poor R wave progression. You get a leftward or a clockwise rotation of the heart. So all those are things if you're getting deep into your 12 leads, those are some of the EKG changes we'll see. And here's here's one on a COPD patient. You can see that axis deviation and the pulmonale, and then the low QRS voltage, particularly in the limb leads. So some of the things we see with emphysema: weight loss. As the disease progresses, these patients, and I'm going to say male patients because oftentimes they are, but they start getting very, very skinny. Well, first off, they can't really do any physical activity, so they don't get any exercise to speak of, but they use so many calories just breathing that we see that weight loss. Again, don't usually have a cough. If they do have a cough, it's a dry cough, and if they do have a cough, it's often associated more with a pneumonia that they've gotten. I don't really know as I like the term barrel chest, but we see an increase in the anterior posterior chest diameter, and so it comes close to equaling the side to side diameter, and that's why we call it that barrel chest. Now, they tend to be pink in color, again, because that's polycythemia. They have more red blood cells than a normal person does. It's an adaptive change in patients with emphysema to try to get more oxygen to the cells. And then we have hypertrophy of accessory respiratory muscles. So while their muscle mass in general decreases, and some of these people have arms that, just like tiny arms, no muscle mass at all, but yet they'll have muscle mass in the chest because, well, that's what helps them breathe. Now, polycythemia, this is an adaptation, a disease state in which the hematocrit, the volume percentage of red blood cells in the blood, is elevated. Um, Secondary polycythemia, which is what we're discussing here, is caused by either natural or artificial increases in the production of red blood cells. And it's the body's attempt to be able to transport more oxygen, more red blood cells, more oxygen to each cell of the body. And it can occur as a result of emphysema. And what's interesting about this, we can have emphysemic patients who are hypoxic, who are not in great shape, but yet they don't have a bad color to them. They aren't that pale. They actually are still a little pink. And it's because of this process of polycythemia. So we'll also see a thing called clubbing of the fingers, and it's very, very distinctive. You can see there in that picture, the clubbed fingers as compared to looking down at your fingers. Breath sounds, again, generally diminished. We don't necessarily hear any adventitious sounds with emphysema, but we hear those diminished breath sounds. Now, part and parcel with emphysema oftentimes comes right-sided heart failure, and one of the things we see in right-sided heart failure is jugular vein distension. And you can see this gentleman here. You can see that almost looks like the size of a pencil running down his neck. That's the jugular vein backing up. Because the right side of the heart, when you talk about congestive heart failure, we're talking about the left side. But in this case, we're talking about the right side of the heart backs up. When the left side backs up, it backs up into the lungs. Well, the right side starts backing up when we see that jugular vein getting very, very distended. We also see peripheral edema with the person I would call dependent edema. The lowest part of the body starts getting edema. We can see hepatic congestion, so much so that when you have these people with their shirts off, you can often actually see that the liver is engorged, and you can see the bulge there where they have an engorged liver at. Now, again, I don't really like this terminology, but I'm going to go ahead and use it because you guys you're going to see it. And we often call our emphysemic patients pink puffers. We call them pink puffers, well, because of that extra red blood cells that they have, that polycythemia. So they don't really have cyanotic. They usually have a good color to them. When we see that pursed lip breathing, that attempt to develop some PEEP, and they're short of breath, hyperresonance on chest percussion. I got to tell you, I've never been good at hearing hyperresonance, but they're orthopnic. They need to be sitting up to breathe, and that barrel chest, again, that anterior posterior diameter starts getting larger. Exertional dyspnea, we see that. We talked about the prolonged expiratory time. When they breathe in 1 second, breathe out, they do it against those pursed lips over 3, maybe even 4 seconds. When they talk in short, jerky sentences. They oftentimes have to take a breath every word, or every 2 words, or every 3 words. They're oftentimes anxious because they're hypoxic, and they use accessory muscles to help them breathe. And oftentimes they're lean, sometimes downright skinny, because once again they're using all that energy to breathe. All right, well, let's jump course, and talk about chronic bronchitis. In chronic bronchitis, what we have is an increased number of goblet cells, those mucus secreting cells in the respiratory tree, and we have a huge production of sputum. Again, this is generally uh, almost exclusively after prolonged exposure to cigarette smoke. Now, remember in emphysema, the alveoli were affected. In chronic bronchitis, they're not severely affected, and diffusion remains normal. But we start seeing the bronchi become infected. And there over on the left, you have a picture of a normal bronchi. And then on the right, you have the picture of a bronchitis bronchi, and you see both the inflammation of the bronchi and also all the mucus in there. So it greatly decreases the amount of area for air movement. So gas exchange decreases because we're not getting those gases down to the alveoli, and it results in the patients being hypoxic, low on oxygen, but also hypercarbic. They have high CO2 levels. Oftentimes have a history of heavy cigarette smoking. Yes, it occurs in non-smokers, but not very often. And the marker of chronic bronchitis is they have a history of frequent respiratory infections. So they produce, this is the diagnosis definition of chronic bronchitis. Produce considerable quantities of sputum daily, productive cough for 3 months per year for 2 or more consecutive years, overweight, they can be cyanotic, blue bloaters, we'll talk about that again, and they have rhonchi and occlusion of the larger airways with mucus plugs. So, um, yeah, it's chronic. It's not something that comes and goes, but something that stays. They may exhibit signs and symptoms of right heart failure, just as we do on our emphysemic patients, or that cor pulmonale. Right heart failure people, um, fatigued, high peripheral venous pressure, so they have a high blood pressure. Ascites, a collection of fluid in the stomach that makes their belly enlarged. They also have an enlarged liver and spleen. Dependent edema, saying your feet are down, you get edema in your feet. We'll see weight gain, distended jugular veins, and again, that right-sided failure, oftentimes secondary to chronic bronchitis or emphysema, either one of them. So, what are our management goals? Well, to relieve the hypoxia and reverse the bronchoconstriction. So, supplemental administration of oxygen, make sure you have a good airway. Get the pulse ox on, figure out the patient's O2 saturation, but also ask the patient where they're usually at. Um, Administer supplemental oxygen. You really want to try to titrate to get the oxygen saturation between 90 and 95%. If we have to, we'll support ventilation with bag valve mask, obviously. But again, this is one where we're going to be very, very quick to go to CPAP. In both emphysema and chronic bronchitis, one of the CPAP obviously forces that air down into the lungs so we can get it all the way to the alveoli. Um, in emphysema, it helps keep the alveoli inflated. It helps splint the bronchioles. In chronic bronchitis, it works, but it helps splint up. It helps open up the bronchi. So absolutely, we can use CPAP in COPD. Um, Chronic bronchitis especially is very well treated with a bronchodilator medication, Duonebs, albuterol and Atrovent, through our small volume nebulizer. Now I don't like it in this picture. I like having those tubes on the end so we don't throw so much of the medication out into the environment. So Preventol, our albuterol, our dose is 2.5 milligrams in 3 milliliters of normal saline. We can mix it with Atrovent, 0.5 milligrams through a nebulizer, and run that in over 15 minutes. And again, I kind of harp on this, but remember this does go in over 15 minutes, so you only have to set the flow meter rating at about 8 liters per minute. You'll see people cranking it up, trying to get them in quicker. Doesn't do any good, just more of the medication goes out into the environment. Region 7 protocols say that we can repeat that breathing treatment times 1 after 15 minutes. So we can do a repeat on it. Now, again, I don't really like the terminology blue bloaters, but it's out there. You're going to hear it. The people are going to have a dusky, that's the way I like to term it, even a cyanotic, reoccurring cough and sputum production. Oftentimes when you go into this person's house, they're literally going to have piles of Kleenexes sitting next to them that they've been coughing into, spitting up to. They'll be hypoxic and hypercapnic. So not only are they low on oxygen, they're high on carbon dioxide. Because of that, they're acidotic. They'll be edematous. They'll have swelling, especially to the lower extremities, to their legs and their feet. Have an increased respiration rate. So this is one of these where, yeah, maybe they are breathing at 22 or 24 a minute. That may be their norm. Exertional diabetes, probably a good history of cigarette smoking. They may still be smoking cigarettes. You'll see that clubbing of the fingers and cardiac enlargement and use of accessory muscles to breathe, and then the signs and symptoms of cor pulmonale, right-sided heart failure. So here we have a comparison between the two, between emphysema and chronic bronchitis. Onset emphysemic patients are usually a little older. We don't usually see people actually diagnosed with emphysema until their 40s or even into their 50s. We'll see younger people with chronic bronchitis as young as their 20s or 30s if they have that significant history of cigarette smoking. Skin color, remember the emphysemic patients have that polycythemia. So oftentimes they don't look that bad. They're still pink because they have all those extra red blood cells. Whereas our chronic bronchitis patients, I call it dusky. They're not really truly cyanotic, but oftentimes just that purplish, darker colored. They can be cyanotic. Emphysemic patients are always short of breath. It's either mild to moderate. When you get to the chronic bronchitis patients, they always have moderate shortness of breath, but it can be easily exacerbated, can be easily made it worse, and sometimes very, very severe. Body types, our emphysemic patients are usually thin because, again, they use up all that energy to breathe. Chronic bronchitis patients tend to be obese, tend to be a little heavier. Emphysemic patients, as far as infections go, not usually, but with that being said, they are prone to pneumonias. Chronic bronchitis patients, often infection. That's a marker of chronic bronchitis. They have chronic infections of the bronchi. History of smoking, emphysemic patients almost always, chronic bronchitis patients almost always. The cough, emphysemic patients, yeah, they have a cough, but it's almost always non-productive. If an emphysemic patient has a productive cough, it's probably secondary to a pneumonia, not actually to the emphysema. And then our chronic bronchitis patients, they always have a cough, and it's always a productive cough. They're always bringing up sputum. Now, we do want to talk at least a little bit about the hypoxic drive. In everybody else, and you guys, what sets our drive to want to breathe are called the central chemoreceptors. The central chemoreceptors are located up in the brainstem, in the pons, and they actually monitor the cerebrospinal fluid. They monitor the pH of the cerebrospinal fluid, and that pH of the cerebrospinal fluid is set by carbon dioxide levels in the body. So you can say chemoreceptors monitor carbon dioxide levels in the body, but it's about a three-step process. Now, when these carbon dioxide levels get high, a signal is sent to speed up our breathing, to blow off excess carbon dioxide. So the levels of carbon dioxide are what actually dictates how a healthy person, how fast and how deep they'll breathe. And there you see where the receptors are up in the medulla oblongata and in the pons right above it. So in the brainstem is a good way to say it. Now, we have another set of receptors, and everybody has these receptors. These peripheral chemoreceptors are sensitive to the levels of oxygen in the body, and they'll send a signal to breathe when the partial pressure of oxygen begins to fall. This is referred to as the hypoxic drive. It's the drive that tells you to breathe when you're hypoxic, when oxygen is low. But in a normal, healthy person, this has a very minor role in telling us how much we want to breathe. And these are, again, located in the aortic bodies, in the aortic arch, but they're also located up in the carotid bodies, up in the neck. So we have 4 different of the peripheral chemoreceptors. Didn't want to jump to the questions that quick, but COPD patients chronically are hypoxic, and so they can't drive off the central receptors. They have to drive off those peripheral receptors. So I have hit the half-hour mark on this. If anybody has any questions, you can post it on the Facebook page, or you can send me a note and email, and I'll be more than happy to answer them.